So welcome everyone to the Opioid Settlement Fund Advisory Committee meeting on June 17th. I want to start off by doing the Pledge of Allegiance. Everybody stand. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay. All right, so an announcement that under Mass General Law, Chapter 30A, Section 20F, this meeting is being recorded. We are going to move a couple of things on the agenda only because we had a speaker from the Massachusetts Alliance for Sober Housing that was supposed to appear at 6 o'clock. She was unable to attend, and our next speakers are coming around 6:15. So I'd like to just quickly address perhaps the approval of the April 15th minutes. Are there any changes or objections to approval? All right, so I'd like a motion to approve the minutes of April 15th, 2025.
So moved. Second.
Okay. All in favor?
Aye.
Aye. Okay, that's approved. All right, so I want to hold off on the questionnaire because David is not here and he's part of that. An update that I'd like to let the committee know about is there's some changes happening with the reporting for the abatement. So it has been done by Mass Care. They have organized all the reporting of expenditures, how the money is being spent, and it is being moved to the Mosaic, which is it's run by RISE. And as of July 1st, they will be managing all the reporting. So I went to a meeting, and in that meeting, they said that they will not be, fiscal year 2025 will be done and completed in October, so we have some space, because I wanted to report for this year, and I was told that I was not going to be able to because of this change. But I went to a meeting, and the meeting, they said it was going to be good until October, so I have enough time to learn how to do the reporting. As of now, the only expenditures that we have made have been administrative, and they've been minor. We are paying Bob for doing the reporting, the minutes for us, and we've done a mailing, which required printing and required stamps. So that is an update regarding the abatement agreement reporting and just in any money that has been spent so far. So that will we'll continue to talk about when I know how the reporting is done, then I can share that with the committee. Are there any other member updates?
You want to wait on the
I want to wait on the mailing and the survey. I'll wait a little while longer to see if Dave comes, but we will do that. Is there any other member updates?
I have two.
Okay.
Just to keep records, not one, but since January 1 to June 17th, we've had 3 non-fatal overdoses within our community, which is a significant reduction from last year. Of the 3 successful contacts with a family member or a friend were made, and they accepted information and assistance regarding the outreach team, which is great to hear, regarding our officers going out with a clinician and offering services.
You said to all of them?
Yeah, to the other 3, they went,
There was 3?
3, and each time people were receptive to receiving information.
Great.
Last night, I was in front of the board regarding August 5th, which is National Police Night Out, which is a big community policing collaborative. And I want to extend an invitation to the committee to be there that evening if we want to host a booth or have some informational stuff for that. It's from 4 to 8 p.m. It's at the old high school. It'll be outside, unless weather permitting, then hopefully we'll be inside. But I want to extend a formal invitation to the committee if we want to come up with something
Nice.
for that evening.
Can you say the date again?
August 5th, Tuesday, August 5th.
It's National Night Out,
National Police Night Out.
Police Night Out.
Yes.
So it would be good for us to think about what we want to communicate to the community. Since we are a relatively new committee, it's a great opportunity for information about what we're doing and about the funds and how the funds can be spent. But also, it might be a great, since it's in August, and if we were looking at our timeline, which is another thing I wanted to discuss, we were looking at beginning to ask for RFPs at that time, if we look at the schedule, so, the timeline. So that might be, in the July meeting, we can solidify what we would plan on doing for the August. I certainly will be there. So.
Another thought is it could be an opportunity to partner with, FAST and harm reduction folks to have them, because they had a lot of great resources and info
Sure.
that we wanted to get out. So to code table, or at least have some of their resources, including harm reduction stuff.
Okay.
And it's not so much, to me, it's not so much literature, but also what other resources can we provide,
Right.
If there's Narcan, we can provide that day,
Yeah,
or other
yeah.
things that we can provide as
Yeah,
well.
that'd be great.
So if you would like, I can reach out to Nikki Fontaine.
Okay.
I can reach out to her just about that date. I just don't know if Fall River's doing one as well that night, because it's a national, and see what resources of personnel they can help us with for that evening.
Great.
We may be able to get someone from Star, too.
Okay, yep.
Okay. Thank you for that update. That's encouraging to hear that it's down. Do you
is.
remember how much, what percentage
It's
or
funny, when I
numbers?
read it, I'm like, I should have this answer, but I don't. It was emailed to you later in the day, but that's something I can follow up. I just noticed the number, I'm like, wow, that's a significant reduction. And Michelle, who does Detective Dunn, who does our stat, she's like, it is, and it's actually been down throughout the Commonwealth
Yeah, yes.
And this is since January, you said?
since January.
To present.
To present, since, as of today.
And do we have an understanding of why that is the case?
I would like to know. I think hopefully it's just us meaning the community's getting together and recognizing the issue and coming up with a team approach for it by each community. Other than that, I don't know why there's such a reduction.
And the numerous webinars and things I've been going to recently, I mean, they talk about the impact of Narcan reducing the deaths. So in terms of how many overdoses there are, but in terms of reducing the deaths. And is that the number you're talking about, deaths or overdoses?
We have overdoses, non-fatal overdoses.
Non-fatal.
Yes.
Right, very good.
That's good.
Okay. I see people sitting in the hallway. Is that our STAR group in the hallway? You can come on in now. I invite you to come up and have a seat. Our first speaker was unable to attend, so you're up a little bit early. I didn't have you in a time, I just have you in that order. So I'm Donna Amaral, I am the chair of this Opioid Settlement Fund Advisory Committee, and Val is the vice chair. If everybody could just introduce themselves.
Pam Clarkson, I'm a parent, lost a child to an overdose.
Chris Dunn, I'm the chief of police.
Nice to meet you.
Craig Dutra, I represent the Select Board.
Okay. And if you could introduce yourselves.
Sure, my name is Jen Ferreira.
Could you talk more into the mic or pull the mic forward?
Sorry. Jen Ferreira, Executive Director of Training and Clinical Operations at STAR.
And I'm Sherry Ellis. I'm the CEO at STAR.
Thank you both for coming here today. The purpose of your being here is to tell us about your programs. We are aware that we have residents in Westport that receive treatment from STAR. And so we'd like to hear from your viewpoint what services you provide and how you may be helping our residents. And then we'll have questions for you.
Sure. So we have Westport residents in a number of our programs, including in our medication for opioid use disorder programs, including methadone and buprenorphine, you might know as Suboxone. So STAR has a fully inclusive and wraparound system of care. So we have a community health center where people can seek their primary care as well. And that was really started as an adjunct after the organization was started 50 years ago as a substance use disorder organization, because there's bias that people meet when they try to find primary care when they have a substance use disorder. So some of those patients are actually served in our primary care as well, receiving all of their general primary care, urgent care visits, everything from infectious disease, foot care, anything. So all of that is available to Westport residents. In addition, we have a rapid access to care model that anyone who walks in the door that day gets taken care of. So if someone walks in and they say, I have a substance use disorder and I'm ready to try something now, they are evaluated by a master's level clinician, and they can receive anything from being told, okay, at the level that you're sitting at right now, you're most appropriate for detox, and they get sent across the parking lot to detox. They may have not been using for several days, so they don't require a detox, but they're really struggling with keeping their sobriety, so they may be leveled as our 28-day residential program known as our CSS, which is basically a step down, but we're one of the few CSSs in the state who will admit directly for somebody who hasn't been using over the last few days. In addition to that, we can admit them directly into our bridge clinic and give them a buprenorphine script that day to bridge them to their next level of care, either into our own, what we call OBOT program, which is our I'm going to use Suboxone for you so that you know what I'm talking about, but our own Suboxone program, where they're followed consistently by a nurse case manager who's assigned to them and follows them through and calls them in between visits and makes sure they're doing okay, provides any services to get them into other services. If they call and they say, this is happening, I can't afford this prescription, helps with getting them connected to a navigator who will help them with the Medicaid application for secondary backup Medicaid or for primary Medicaid through Mass Health. In addition to all of that, if they don't have primary care, our MAT program, their Suboxone program, will connect them into our primary care at that point and get them the first available for a primary care physician. If they are found to need methadone, we can do the intake there, send over for methadone. We, last summer, with a lot of effort and a very tight budget, started same-day induction of methadone treatment every day. So what happens is that if somebody comes in, we ask them to come really early in the morning. They come in, they'll see the clinician, they'll see the nurse, and then they will see the medicator, and they will leave that day with their first dose of methadone, and that inducts them into the clinic, so every day thereafter they come back for their methadone dose. We also have a mobile van where one of our community doctors goes out to the shelters and goes out to the rail trails and will encourage patients to come in. They will park at different places. People know where they're parked. It gets around in the streets. And our doc will do everything from hepatitis, AIDS care, hepatitis and AIDS prevention care, and education, to foot care, to general primary care, to wound care, to initiating either buprenorphine or either Suboxone or methadone right on the van. She does the full doc intake. She enters it right into our electronic medical record, and that pushes over. So she will give the buprenorphine, the Suboxone script right there. Or if methadone is a better source of treatment, which for fentanyl it often is, she will then have one of the outreach workers drive that person over to the methadone clinic to receive their first dose, and then they'll set up transportation through Mass Health for that person to be transported every day. Or sometimes the FAST team will do it. STAR also has a contract with the city of Fall River to do the CARA program, which is ending, unfortunately, in September, which has been incredible. We deliver Narcan and Narcan training all over the area, including out here. We train first responders. We train first responders in how to kind of work with patients and clients that are kind of in the throes of having a substance use disorder, or even talk to them about de-escalation and mental health disorders. And we do distribute Narcan for the CARA grant. We run community events. We have tables at all community events where we're invited. where people can get to hear about the programs, get to hear about how to access Narcan, how to get it. The laws have changed now in Massachusetts, and BSAS, the regulations have changed, and BSAS is requiring that we release everybody with Narcan prescriptions when we're releasing them from any program. So even if a person says, I'm leaving, I'm blowing out of detox, I'm not staying here, we release them with prescriptions for 2 sets of Narcan, so that they can pick those up at the pharmacy, and those are paid for by Mass Health. It is getting harder, I will say that. It is getting harder to access free Narcan. It's getting harder to have enough Narcan to go around, because a lot of the funding sources are starting to dry up for that. We have lost incredible amounts of funding in our rapid access program, and that has made it much harder to maintain it and to maintain every day. We had funding for 7 years that supported about $800,000 worth of what it costs us to run the rapid access program, and that has all been lost. So we're kind of cobbling it together and changing it around a little to try to be creative and innovative about how we can continue to serve patients. I will say that the current needs are going to be extreme next year for this population, because the federal mandates and the federal changes to Medicaid and Medicare are going to be devastating for a really vulnerable population, as well as the fact that all of our research grants have dried up. We've been on the cutting edge of research at STAR. We have a very good research program. We've worked with Columbia, BU, Brown, all of the major universities around staying at the cutting edge of what we're doing in treatment. We moved to microdosing for our medications on our inpatient units before many others did, because Jeannie Bailey, who runs the research program, who's a dual certified psychiatrist and addiction medicine doc, has always been at the cutting edge. We also have prevention programs. This year, we started a mobile van to Durfee High School, where we can deliver primary care and also make sure that we get to kids who aren't getting other primary care services and other medical care, so that we can at least get them involved in the system. And then we have a prevention program with kids that we run through Sheila Kaufman, who stays in all the community events, works with the schools, and tries to work with a lot of foster parents, foster care parents, and pick up kids who might otherwise fall through the cracks, so that we can get them before they do that. In addition, we have a contract with the schools where we're providing, it's through a grant, where we're providing the clinical care in a program called the PASS program, which is kids who are found to have low-level drug offenses. And that could be a simple vape, that they were vaping at school and they're suspended. The parents are asked to have an alternative to in-home suspension and send the kids over to the Boys and Girls Club, where we run a full therapeutic program every day. And the kids get psycho-ed around addiction, treatment, and even cognitive behavioral and DBT skills. It's a master's level clinician who runs those groups as well. I'm trying to think of what else I'm forgetting.
You've covered quite a bit.
I know I'm forgetting things. In Rhode Island, we run a program for pregnant and parenting women and their children who have substance use disorders. So we house up to 12 women in Rhode Island. Massachusetts will not pay for it. It's out of area. But I don't know how flexible you want to be with grant services, but the women need to agree to go, and their child goes with them, and there are daycare services within. It's a licensed daycare within the facility, and it's run as a therapeutic residential, and there's group treatment and individual treatment, and there's chores. They all do, they have a common kitchen, and they all cook and clean and do the chores, and they each have their own rooms, and their children are with them in their own rooms. It's a really amazing program, and that's called Star Birth. I don't know. Oh, Project Aware. We have a specific program for harm reduction, HIV, hepatitis, and AIDS treatment and prevention. And that's called Project Aware. We actually have 2 vans, because Project Aware and the community doc go out on one some days, and the Durfee van goes to the other. So we're pretty spread on our community services. We have recovery coaches and recovery support navigators who will work with anyone coming through our services. Mass Health pays for those services, and you can connect a recovery coach with someone. The benefit of recovery coaching is that those people have lived experience, so they have empathy for every patient who they work with, and they can help them get connected to the system. They can help get them to NA meetings, AA meetings, Al-Anon meetings, anything that supports their recovery. And they're basically there to support whatever that person needs in creating an environment for them that's sober. I think that's.
Women's Center?
Oh, we have a domestic violence program that's not aptly named the Women's Center.
right,
Because we take men, too, who are victims of domestic violence. And in addition to that, we also do MID groups. So we have the first and second offender driving groups. And then we have intimate partner violence groups that are court mandated. So people are referred into those groups and they have to complete them as part of their probation or a part of their pre-probation. And we do.
have family intervention.
The Arise program, yeah.
The Arise program,
There you
yep.
go.
Yep, great.
Another one of my favorite programs. For those of you who.
Talk a little bit about the Arise program and what you do.
So Nancy Matheny is the head of it. She's our interventionist, so she works directly with families to help their loved one, decide whether or not they're going to seek treatment. And then they also run groups. I think it's 2 groups per week,
Yeah, I think
family
I think
support.
they may have merged it into one, but it's a pretty large group. And the family can be at any place in their journey. So she has some parents who are just finding out that their loved one or their child, and it doesn't have to be necessarily a parent, but she'll run them for people involved with loved ones who they could be anything from the person, they're just coming to the realization and they're trying to figure out how to help them. Or it could be a parent who lost their child. And the group is interesting because Nancy will share that some of the people who come are in the very early stages and others have already lost a child but stay in the group for years.
They support
because-
one another.
And support one another and just love being in the group and doing that work with them. But Nancy also does individual interventions with families. Like, how you see intervention on TV? It's kind of like that, except these aren't people who can afford paying thousands of dollars, but she is a certified interventionist. And basically, she meets with the family, and the family gets the loved one in the room, and they do a piece of work so that, in a very non-judgmental way, to help that person realize that the family is just there because they love them and they're worried about them. And then if they can get that person to agree, Nancy will segue them into our detox and bring them in for services. And she is pretty amazing. I get it, you know her.
I know Nancy.
You know, she's amazing.
Yeah, the support groups are every Wednesday night at 6, I believe.
I know that I see them often as I'm going out the door. It's a pretty large group now.
Mostly women, but some men go.
Some, yeah, I see both coming in. So that's what we do, and we do whatever we can.
So one of the questions I have is we're well aware that there are people that live in Westport that are receiving help and support through your program. Do you have any general numbers for us so that we know how many people that you're helping?
We have 60 enrolled just in our MAT and MAT programs. And when I say MAT, in this instance, I'm including both the Suboxone Clinic and the Methadone Clinic. And that's just with Westport zip codes. That does not include people who end up in the encampments in Fall River that are from Westport as well. It's harder to track those. And it doesn't include anyone unhomed who's like couch surfing. So that's just the numbers that we could get zip codes on. And that doesn't include anyone going through detox or residential or through rapid access either. We just ran them for the ongoing MAT programs.
Okay. So 60 Westport residents that you know are receiving medication-assisted treatment. I'd like to emphasize that for anyone who's watching. We are being recorded. I don't know, are we live, Carrie? No. Okay. So that the community's aware, even though they might not think there's a problem, that there is a problem. And that we are tasked with trying to figure out how to use the funds that we have and that we will be getting in order to support those people who are getting treatment, getting assistance, but then for those that are not. So I'll open it up to unless you have something else you wanted to add. Did you want to?
No, I think we covered
You just came
everything.
for moral support?
Well, Jen is
quite
new.
Okay, okay. Well,
My
well,
third month with Star.
well, welcome. I have a dear friend who used to work at STAR. She was one of the therapists there, but she's retired. And I have also had the good fortune of doing a presentation on dementia. I'm a psychiatric nurse, and I worked at the Center for Behavioral Medicine in Fall River through St. Anne's, which is now closed, but I did a presentation there some time ago. So I know the great work you do, but you're here because we want to know, we want the community to know what great work you do that can help them.
Yeah, and you know this, but I'm going to say it just because your community is here and listening. Medications for opioid use disorder are very well documented as the best course of treatment for opioid use disorder. And I know that many people have a perception that giving medications for opioid use disorder is replacing one drug with another, and that's not what we're doing at all. It works totally differently, and it's life-saving. And the evidence is so well documented in the research. So we pair it with counseling, and we pair it with group, and we pair it with everything, which is the best chance at outcomes, but even the medications alone are well documented to save lives. And Narcan is another thing that is essential to save lives. And your communities have had one of the highest rates of overdoses, especially in Fall River, which is, and it's come down exponentially since the Narcan distribution came up and the Narcan education came up, and first responders were starting to be trained with Narcan. So the numbers look so much more in line with the rest of the state, whereas they were so high when I first came to STAR just 3.5 years ago. So it's really exciting to watch the work having an impact.
Like, any members of the committee want to ask any questions? You do, go ahead, Val.
Well, first, I just wanted to say thank you for coming, and also for your partnership and willingness to help with surveying, or at least reaching out, helping distribute some surveys to try to better understand some of the barriers and needs for Westport residents you serve. So we'll, going forward, hopefully understand a little bit more about that directly from the folks, or some of the folks you serve. So I'm hearing what you're suggesting is some priorities around access to MAT and Narcan, especially considering a potentially narrowing pipeline of free Narcan from the state. So would love to hear that may be addressed by state funding or advocacy that we can
Well, I'm
engage
just wondering,
in.
is it a supply chain issue, or is it a funding issue?
I don't know I know that I'm at Bridgewater State, and we just got registered as a community naloxone provider. But of course, nobody knows what the budget will be next year. I don't know what the state gives out is federally funded. So what can you share about that?
I mean, the federal funds are drying up on so many fronts, and I think that's part of the issue, that with this current administration, there's been so much disappearing of money. And part of it is that as they're posting grants, they're pulling things off of a lot of the grant sites because the mandates around the language that can be contained in a lot of these and the words that can't be in them has been so burdensome that we're not sure if everything's being pulled down because they can't even scramble to get their own language in line with their own executive orders, or whether it's truly just drying up so much of it that there's going to be less funding. Our sense, given what they're doing, what's happening on a federal level to Medicaid at this point, is that a lot of things are going to dry up. Right now, the best source of getting Narcan for our patients is to give them a prescription and they have Mass Health and they fill it. At this point, Mass Health is going to be changed, and it is going to affect people of Mass Health. And I think what we're going to see is a lot more patients without any insurance at our doors. Because if on a federal level there becomes a work requirement where there's a work or school or volunteering requirement for Medicaid recipients, it's not that most people don't do that. Most of the Medicaid population has some work or school requirement. However, the administrative burden to prove that all the time and continue to keep registering as that is really difficult for our population. They're already disenfranchised, there's transportation issues, there's educational level issues, there's access to technology issues. So people are just going to fall off for periods where you see the mass health population reduce because Massachusetts can't do away with a requirement like that because they won't get the matching funds. So and we're also a federally qualified health center. So as a federally qualified health center, we're really concerned about what's going to happen to our patients, as well as all of our substance use disorder programs. We see those kind of mandates as something that will have people fall off and have no coverage for a while. And I think those are the gaps that we're all going to have to then try to fill in. And I think that not only Medicaid, Medicare is also up for some changes too. So it will be interesting to see who qualifies for Medicare for disability and what that covers, let alone starting to, if everything goes through with a copay for Medicaid, again, we may find a $5 copay something that's totally doable. People who are living at the poverty level, that's not doable. That becomes the difference between buying a very simple dinner and getting Narcan. All of those things, or getting a medication that you need. So I think that 2026 is going to be really a challenge year for all of the social services providers because of what's going to happen in the Medicaid realm. And I think that's a huge concern that we need to consider as you start to think about where do we put our resources and what are the gaps going to be next year. So I think that's why I'm kind of focused on Narcan a bit, because I think that we're going to see it be pulled back.
My only point was, if Narcan, the supply of Narcan is largely related to largely federally funded programs' ability to get paid for them or to purchase them, then before that gets going too bad, the pharmaceutical companies, as part of their business planning, may actually choke the supply chain before the federal cuts come in to do the damage.
It may. I mean, that has been a concern for us because since they mandated us sending everybody out with 2, we've been waiting to see if the pharmaceutical industry will be able to keep up with the demand for Narcan. Right now, we have not seen a problem. However, given the BSAS changes in Massachusetts, I'm really wondering, as we rev up and always give everyone 2 prescriptions, what starts to happen, and will there be enough in the system?
My understanding as well, Olive Wachurski, who is, she's the one who spearheaded us starting this committee. She's the one who inspired me to get this committee together. So she expressed really concern about us saving funds in Westport so we can buy Narcan if the fact that the federal government no longer supports it financially. So, and that there was some talk about what's happening, with the cuts and how that's going to impact everything. But she was concerned that whatever decisions that the committee was making, that we take that into consideration, that if those funds are drying up, that we may want to set aside funds to support our own Narcan purchasing and distribution, so.
I
Yes.
have a question. How many therapists work at STAR right now to serve even the 60 people from Westport?
It depends which program. So we have,
Let's say the medically assisted program people.
so.
Are they being mandated to have a counselor in your program?
So there's, in the OTP, so when we talk about a methadone clinic, it's called an OTP, that's the licensing. And that program has very strict requirements about how many people per. And however, I will tell you that the regulations loosened up. And it used to be that to get your methadone, you had to go to treatment. And what has happened is everybody's come around to a harm reduction model. What is the greatest way to do no harm? And so for people who were coming in and they were consistent with their methadone, and they used to be cut off if they didn't come for their therapy, that is stopped. So there's a requirement that we have the availability of those clinicians, but not to stop the Narcan or discharge somebody. It used to be that, okay, if you hadn't had a therapy visit in this, you got discharged. That doesn't exist anymore. And for better or for worse, it is a harm reduction model, and we do know in the literature that medication-assisted treatment alone does improve outcomes. Now, is it better when you add on the clinical? Absolutely. So many of our patients, and I'm not going to say all because I never do it that concretely, but so many have trauma in their lives. And so when you treat the trauma while they're getting the medication-assisted treatment, you're going to produce longer-term outcomes of just basically becoming the best person that they're capable of because they're getting help with everything they need. And we also do a lot of mental health treatment. So we have 7 psychiatric nurse practitioners as well, because you can't treat substance use disorder without treating co-occurring illness. So we've really expanded that program over the last 3.5 years. I'm a clinical social worker by training, although I've been doing administration for a really long time, but I have clinical roots, and so we really have expanded the mental health piece of it. So I think you have, what, 7?
NPs?
No, no, we have 7 psych nurses, but
Yeah, clinicians right now, master's level, about 7.
and 3 more.
So
three more
7,
3 more coming. Yay.
Yeah.
7 psychiatrists and 7 therapists to how many people in the clinic?
Well, and then over at the OTP, we have 6 other clinicians, master's level clinicians. And then in the buprenorphine model, we use a nurse case manager model. So we have 7 nurse case managers who manage all of the treatment for those patients. Now, some of those can be in mental health treatment with our clinicians. It's not mutually exclusive. So we have people who span across the programs, but the OBOT one is really a nurse case manager model for the Suboxone. So some of those do have clinicians. We also have an intensive outpatient mental health program and an intensive outpatient substance use disorder program, which is about 3.5 hours a day, 5 days a week. And so if people need that level of care and that intensity, they can be moved into the intensive outpatient to receive their treatment as well.
I think from experience, my concern is that when someone is really struggling and they need medication from a psychiatrist for sleep, because they can't sleep or whatever, anxiety, all the things they suffer from when they're detoxing, they have about an 8-week wait to see a psychiatrist.
So
After,
they can walk into Rapid Access to see one of our psychiatric nurse practitioners. It is true that the waits are extensive, and honestly, if you can find somebody in another organization with an 8-week wait, that's amazing, because most of the nonprofits around that are running more like 6-month waits. We do see people pretty quickly, and we put them in, what are we getting them in with the psychiatric nurse
For-
practitioners?
A few weeks.
Yeah,
Yeah.
pretty quickly. Now, our
Ideally.
primaries tend to, because our primaries are used to having their patients have co-occurring illnesses, our primaries tend to prescribe until we can get them into.
oh, they do.
Oh, yeah. That's why it was started. And our primaries have been taught to work in a harm reduction model as well, because some primaries will shy away just because somebody's on buprenorphine. They'll negate the need for sleep aid, but our primaries, it's nice that we have interdisciplinary, so we'll have interdisciplinary rounds, and we also have a high-risk case review where the docs from the medical center and the docs from the Bridge Clinic and the substance use disorder. We have a substance use disorder doc now who's an addictions doc, and she will kind of run the rounds for the addiction piece of it with the other docs. So they'll throw a case out that they're worried about, and she'll make recommendations on medications, and they'll go through the entire thing. Or if somebody's really struggling with what to do with a patient in the health center, they'll bring them to high-risk rounds. If one of the psych nurses is struggling because the meds feel overwhelming and they know that there's an addiction, and they also think they might be on too many benzos from somebody else that they came in with, they'll take them to high-risk rounds, and then they'll kind of meter out how to manage that patient, and they'll titrate really slowly down, because if you try to whip somebody off of a medication too quickly, you'll lose them to treatment, number one, and you may then put them in crisis about using other drugs to try to take that edge off. So we try to work across the spectrum to make sure that we're managing them. It's not easy.
I know.
The job's a hard at start. If you have any friends, loved ones, relatives who are looking, please send them to us if they're clinical. And we're all facing healthcare worker shortages, so. But always
you.
happy to entertain applications.
Any other questions from the committee?
Of course, I have another.
Go right ahead.
Thank you. So you've said a little bit, but any about sort of priorities for MAT and Narcan, for example, and clinicians? But even though we don't have the specific data yet for Westport residents, either anecdotally or just in your experience with, residents from, rural neighboring towns, what do you think are key barriers or bridges that could be partnerships that would help folks get to you, get to treatment, get to harm reduction resources?
I think making sure that Westport residents know and understand about our rapid access program. And again, I'm going to make a pitch to say we've lost most of the funding and we are struggling to make sure we maintain it, but it is something that we see as mission critical. So when we do hear of towns that have any opioid use settlement funds, we are asking that people look to assist and trying to keep those services running, with maybe supporting a piece of an FTE for the Rapid Access Center. But I think having rapid access to care is the most important thing, and transporting there as well.
Are you getting any opioid settlement funds currently?
We have opioid settlement funds from Fall River, much less than we would have hoped for. It doesn't fill the gap of what we lost from the state as the 7-year funding ended for the Rapid Access Program, just in a natural maturation, and they weren't going to fund that service anymore. But it is helping us to kind of piece it together. We've changed the way we operate. There used to be clinicians that stood at the ready, and now what we do is we rotate the clinicians. So we have the ones who do outpatient and keep ongoing cases. We'll have them free up a slot, so we'll have 2 free, and then we'll flip them to see a patient that they know is coming in, and flip the 2 free slots to those, because that helps us maintain enough productivity in our clinicians to hopefully be able to fund those positions through some third party. But it's a different model than it was before, so we've gotten very creative.
You have, when my friend had worked there, they had therapists who had their own schedules, and it switched over to the model where it was people can come in and see someone. And so I think that's great. It's then, though, for some people, especially in Westport, if they know it's available, then transportation may be an issue. And that's where the FAST program, we're trying to figure out as a committee how we can bridge, right, 2 services that are available for our residents. And whether or not it's through education, whether or not it's through assisting with transportation, whether or not it's bringing a piece here in Westport and having a space in Westport where people could come to. Those are some of the things that we're, looking at, talking about. But what's available now at STAR, are you aware that any of the people who are receiving assistance or help from Westport, any of their barriers? Is transportation a barrier? Is funds a barrier? What are the barriers from people in Westport?
My guess, and I have to guess because we don't keep that kind of data, but my guess would be that it's both, that transportation is a barrier because you are a car ride away, and not everybody has cars, and sometimes the thing that people lose the most when they have a substance use disorder is the support of family and friends, because it's been so hard. and so they can't always find a ride in. I mean, in some of the outer areas, it might be possible, that question is, what do you want to do? Do you want to bring the mobile van in once a week? That's a great source of being able to get kind of ongoing treatment. On the other hand, for people who want methadone, they have to actually go into a licensed methadone clinic. So the question then becomes, what do you have for resources? Where do you want to put them? How do you have the most impact? I sense that's why you're giving the survey out, to try to find out what is it. I think it would be interesting to, it might be interesting for you to create a very simple provider survey where we could give that to the very clinicians that we could look up who's serving the people in those zip codes.
We actually have done that.
Give it to our providers.
Have we given it to them?
We haven't given you, for your providers, for us? That might be that would be a great idea.
Like, look up who's actually serving the Westport patients. Then we hand them out to our clinicians saying, this survey is specifically about these people on your caseload. It might give you some real-time data.
One of the things that we did, and we were going to talk about it, but we did a survey of treaters within the Westport community and sent out a postcard with a QR code with a survey that they could answer. Would that be enough for your treaters, or would you want us to do something more formal for STAR?
We don't need any formality. We may want to do, I'm just wondering, if you give it to us, we'd have to put the zip code we were in. So I assume you asked for a zip code? Or are you assuming it's all Westport?
Val is the one who created
Well, I created the survey, but the distribution is going from somebody who's pulling a list from, Psychology Today or known providers. So
In
they're-
Westport,
In
though?
Westport. So far, we haven't given it to providers beyond Westport, so we haven't asked for that. So I don't think the provider zip code matters. We know Westport residents are getting services at STAR, so the provider zip code doesn't matter. What matters, but there's not a rock-solid way probably that makes sense to do it, is like the verification of, are they talking about their Westport patients? But we could sort of triangulate with the Westport clients,
Well,
comments.
I was thinking the opposite. I was thinking that we give it only to our clinicians who are serving Westport clients to speak to the questions you're asking, which
With
is
the
why you would
clients.
have to know that it's Fall River, because if a barrier is transportation, it's because they're trying to get to Fall River.
Yes.
So I'm trying to figure out how to get you the best data.
Right. I mean, if there are clinicians at your sites, then we can assume it all relates to Fall River in terms of anything, in terms of getting to treatment in Fall River. And that would be, so we might revisit the questions a little bit with that eye. Like, this is a survey for clinicians at STAR in Fall River. Like, that's the given. And then, but it would be for them to discuss with their clients, or for them to just report on.
Report what they
Just to report,
know.
I see.
Yeah, just to report.
I think the phrasing would be, this is about your clients in Westport,
Yeah.
even though they may be practicing and seeing them in Fall River.
Would it be enough for us to create it and then send an email to you with the code that you could distribute to your clinicians?
Yeah, because we can go through the list that we did today and just run who the clinician is and send it and saying, this is in regard, please answer these questions in regard to these patients.
Okay. Yeah, that would be very helpful. We also talked about, Val has been working with you about doing one for the clients. To have the
Yeah, we were
clients-
trying to figure out how to distribute those, because if you gave them to us, you gave us to them in white envelopes, because we won't send it out on STAR envelopes. If you gave it to us in white envelopes, it would have to have, I was thinking about this as we were sitting out there, it would have to have no return address, because if it came back here as undeliverable, you would then have our client name in your hands. And so we would have disclosed by
I
de
see.
facto
Yeah,
that the client was one of ours. The other thought I had is just literally giving them to the sites, especially on the MAT side, and having them give them to the clients, who could then choose
To do
to
it.
send them back or not.
Right.
And that way, if you're getting them, it's kind of an implied consent.
Right, I see what you're saying, yeah.
Yeah, confidentiality, HIPAA violations. You
And
have to be
42
very-
CFR, which is worse than HIPAA.
Okay.
Yeah.
So you have to be very careful, it's very sensitive. But the reason for this, for people who may be watching, is part of our responsibility as a committee is getting community input, getting the people who are involved, family members, people with lived experience who are struggling with opioid addiction or substance use disorders, that we want their input to say, how would they want these funds to be spent? And so we're trying to, as the word that has been used is stakeholders, ask the stakeholders, what do you think? Where would this money be best used? And so this is part of that process. We've done one focus group where we had people come to the library and give feedback. We've done this first survey, which was sent out to all the clinicians in Westport that identify as therapists or other treaters, even physicians, primary care docs, so that we could get their input into what they're seeing happening in their practices and what are the issues that they think we could address. So working with you around this, Val, I know, Val, you've been active in working through this.
Communications, yeah. With Jen, yeah. Yeah, and it's still, very flexible, work in progress, definitely want to respect the parameters and, I'm just thinking right now even about some different language to include in it, but, as I said, we can definitely pay for self-addressed stamped envelopes with no return address, whatever materials, we can print things up, we can.
Could be anonymous, too.
Well, that was what we, there's,
Yeah,
we
we're
would
not
give the
asking people for their
option.
names.
Right.
But we would assume an anonymity unless someone said, basically I think it was sort of contact us if you want to come meet the committee or come talk to us, great. Otherwise, we would value your response.
Is the client one with a QR code too?
Yes. And it's set to not take emails automatically. So you wouldn't know who.
Put up flyers, like in the waiting room.
We could. Are you a Westport resident? So even people coming into Rapid Access would see it. Do you want to help, do you want to help your community decide what to
Right.
do with this to help?
Yeah.
The other thought is, not everybody gives us an email, but it's less likely to be misdirected if we sent it out by email to the clients we know are in the Westport zip code.
I have a question. Would it be possible that, so even just the 60 people we're talking about that are being seen for medication, could they just fill out a questionnaire with no name on it? Volunteer, would you mind just filling this out, and then hand it back to their clinician, and then it's over. We don't need email, we don't need names, phone numbers, nothing.
Well, it's a possibility, but the email, I'm assuming that you just said the email's not going to take email, and it's not going to take, it's not going to copy emails or anything else. So I think we could do it either way.
I feel like if you're going to have them there in person and they're going in to get their medication, you can ask them, would you mind filling this out and tell the reason why they're filling it out? And just do it in person, because the chances are they're probably not going to mail it or email it or anything. They're not going to follow through, because these people do have trouble following through with things like that.
Some, although we have people that are so stable on their medication that we open at 5 o'clock in the morning, because most of our patients who are on methadone and who are on Bube, we don't open Bube till 7:30, but most of our patients on methadone work. And so a lot of them, you'd be surprised, will fill it out, I think, for the ones who are kind of further along in their treatment and more stable. But I'm willing to talk about anything. It's 60 people. If it were 600, it would be an issue because it would create administrative burden for my staff to the point where there's no way that we could do it.
Yeah.
But where we're finding 60 between the two programs, I think that staff would be willing to just say, hey, would you mind doing this? Because this is really about your community and how your community can serve you best. and there's no, no identifying information, and we're going to mail them back in bulk to them.
Yeah, and they could just do it while they're waiting in the
I
waiting
mean, I
room.
tend toward electronic, so that's usually my preference, but.
We could have both. I mean, we could have the no return address, self-addressed staff envelopes, printed out surveys, and a flyer with a QR code, it might be at different settings, or, different forms are better for different people, yeah.
Sure.
And whatever's, again, easiest.
I mean, the thing about doing the QR code is that we do a lot of telehealth too, especially for clients who come for their methadone but can't necessarily come for a full visit, and then we'll have like an evening session with their clinician or a group session. So we may reach more people that way, hard to know.
Well, I appreciate that your willingness to work with us around our data collection so that we can best serve our residents. That will be something that Val and I and David, who had worked on this other survey, we can talk about and get back to you and come up with a plan. So that we can continue to really connect with the people who this really means the most to, right?
Well, I was just going to say, as we're discussing this, I realize that it does call on some staff time and whatnot from you all, so it might be something to consider whether we could dedicate some of the funds, a reasonable compensation for your support of the survey. So I just thought that would be worth putting on the table.
Okay.
That'd be great, thank you.
Okay, if there are no other questions from the committee, I'd like to thank you both very much for coming here and telling us about your program. And we will continue to keep communication open with you because, again, our job is to help our residents and bridge to those wonderful services that are available.
Thank you. And thanks for the time that you gave us to explain what we do.
Oh, you're
'cause
welcome.
It's nice to be able to tell every community.
Yes.
We really appreciate your work, so thank you.
Yes, thank you very much.
Thank you.
Thank you. I am ready.
Get home safely.
Thank you.
All right, so I really appreciate having people from the community outside of Westport come in and tell us what services are available for our residents. Then the rest is, really up to us to figure out how, when we communicate about needing RFPs for people to request funds, where our focus should be and how we can help direct that. So, all right, so going back to our agenda, we already approved the minutes. We had some member updates. We didn't talk about the questionnaire because I was waiting for Dr. Dorsky, who had worked on this. But Val, could you address what we've done so far with our survey?
Sure. So as Donna referenced earlier, there are a couple surveys that we've created, one for providers and one for folks in treatment with lived experience in recovery. And the provider one, as we mentioned, is an online survey with a QR code that has been distributed to a list of folks or via this postcard with some information with a deadline of June 30th requested. And that has been physically mailed out to the list so
It
far.
has been. We had 32 or 33 clinicians in our community, doctors included, primary care doctors, pharmacists, and social workers, mental health counselors, psychiatric nurses, nurse practitioners. So those were mailed out at the end of May. We're hoping, and we asked for them to please respond by June 30th. And if any of you know your therapists, your clinicians, to ask them if they've filled it out, because we've appealed to everyone to fill it out by the end of June. So we have that data.
And we have 2 responses so far, so, and counting.
Okay.
And then the other survey, I think folks heard me just talk about for folks with lived experience, we've drafted and shared with STAR. I also shared with, Stepping Stone via Dina, I can't remember Dina's last name in the moment, who's attended this meeting several times, a Westport resident who's a counselor at Stepping Stone. And she had her clients, I think 6 folks, mostly from Westport, kind of physically fill out. So we have those responses. And then, as you heard, we're working on, getting responses from clients at STAR.
And the other piece is with the school department. I have put a hold on that because as, for everyone in the community, Laura Charette, who is the principal of the middle high school, who was on the committee, had to resign her spot on the committee. And so there is a committee seat open for someone in the school department. What I've been told by the school department is, or by the school board, is that they're waiting for the new superintendent to start, to have the new superintendent have input into who would be recommended to the select board for appointment. So that's what we're waiting for. So I'm waiting on doing the survey of the parents and the teachers because I need input from whoever is from the school department in that process. So we will hold off on that. And as our collecting data, information from the community is going to be ongoing. It's not going to be something we're just going to stop. So we're going to keep collecting data, but we should also, in the data that we've collected and what we've heard from all the speakers we've had, is be able to make some decisions about what direction we want to first ask for requests for proposals. So we talked about the stakeholder questionnaire, the other updates I told you about, the abatement agreement reporting. In the committee planning piece, in next steps, I put plan for collaboration with FAST. When we had Nikki come and speak with FAST, she said that there are so many services and things they could provide and help with, but we don't really have anything solid. Do you have a letter of agreement with the FAST team?
I believe the previous administration signed a letter of agreement with the FAST team. If not, I can look to see. I know when we met her, we as a police department definitely would like to transition to FAST, considering the current clinician we use is out of Easton. So we felt as though we wanted a committee a lot closer. So I'm definitely on board with finding what we can do to work and collaborate with FAST.
My understanding is that there was also a letter with the fire department.
Okay.
And so I was hoping that the chief would be here so that we could talk a little bit about that. If there was a letter of an agreement with the fire department, how do we combine and work together?
Sure.
In partnership? And the other piece to that is with some of what I have heard from other communities. I have attended, I don't know how many webinars I've attended now that had Karen Mass, that had to do with, there was another opioid regional, the Southeast Regional, I have it written down, commission. Plymouth has done a number of things already. But one of the things that kept coming up in all the webinars was a safe station. And a safe station, they have them in Fall River. They have them all through in every fire station in Providence, where if someone's in crisis, they can go to the safe station and say, I need help. And there's somebody there that can help them in that moment, whether it's getting connected with treatment, whether it's transportation to treatment, but they call them safe stations, and every fire station in Providence has one, and Fall River has one. So I wanted to entertain that idea that we look at that possibility and what would funding for that look like. Because that would then take care of, when somebody is in crisis, they know they can go to the fire, and they use the fire station, not the police station, because the police has a different connotation for people. They go to the fire station, and then someone there counsels them, supports them, and connects them with services. So that's one of the things I want to talk to the FAST team about.
Sure.
Can the FAST team help facilitate a safe station? What would the funding look like for that? There are a lot of great programs. Plymouth has done a tremendous job with the distribution of their funds. There are, let's see if I have that written down here. I have so many things on here. But there was, they talked about recovery capital. And recovery capital is not money. It's recovery capital is, does the person have housing? Does the person have social supports? Does the person have help in getting a job if they don't have finances? So that was one of the things that they talked about at one of the Care Mass webinars. I don't know that people are aware of the resources, but there's a fishing partnership, and they are dealing just with the fishing industry. And that was really music to my ears, because I'm originally from New Bedford and from a fishing waterfront family, that they have a certified community health worker called a navigator that helps the fishermen specifically access resources and support and families support. And it's somebody with lived fishing experience. Of course, we've heard about recovery coaches, right? And we have the possibility of getting recovery coaches in Westport to be available, maybe at a safe space, to be able to respond when fire department calls and says, we have somebody here, and they can come and they can help. So I encourage you all to go on the Care Mass site, and they have a lot of these recorded, and see if you get some of the creative things that they're doing in other places was very inspiring to me. The one that they had in Plymouth, it was virtual, the Southeast Regional Opioid Recovery and Remedial Funds. There was the Mass Executive Office of Health and Human Services was there, and the Bureau of Substance Addiction Services. And they talked about Bristol County being the area with the highest percentage of opioid-related overdoses and addiction between Taunton, Fall River, and New Bedford. Now, whether Westport is part of that, because we get services through Fall River. There's parents supporting parents, and the co-responder model, where they have police and fire and paramedics, and they also work with churches to connect with the community. So again, those are some of the things that other communities are doing, and I hope that we can also, think about some of those things. But I think having a place where people can go when they're in crisis would be a great model to follow.
I agree. I can coordinate I'm going to contact Nikki anyways regarding the National Police Night Out, so I can just piggyback off of that with that question.
Would you be able to follow up with the fire chief to find out if they have an agreement?
Yes, no, I actually put that down in agreement as well.
Yeah.
Letter with the fire department. I put
Right.
that as well. Yep, I can coordinate with Chief Baldwin.
All right, that would be great. So as far as next steps, because the FAST, when we had Nikki come here and talk about the FAST group, what they do in Fall River, that was eye-opening, I think, for a lot of us. And how do we access that and work with that group to bring services here or to create services here? So. Are there anything else in next steps or planning that people can think that we need to do?
We were talking about maybe collaborating with other small towns like Dartmouth and putting our funds together to maybe have, if we did have a walk-in center, it would also include like Dartmouth and, maybe, what were we talking, Dartmouth, Fairhaven, the smaller towns that don't have as much funding as the big cities have? So has anyone talked to anybody from the towns, the smaller
I
towns?
think that was police in particular, thinking about a police agreement for the co-first responder. That was at least one thing that I recall.
It wasn't. I think it unfortunately got pushed off a little bit because the grant that we're having, we're part of the collaborative, the law enforcement side with officers going out, seems like it's going to stop, the funding's going to stop in September, so everybody's kind of figuring out where they're going, what they're gonna do. I know they put in a letter of extension in the grant, they just don't know if they'll get it. I have been in touch with Chief Levesque in Dartmouth, Chief Dorgan in Fairhaven. I know they use their own clinicians, and that's where we talked, right, that's when we reached out to Nikki about FAST, we heard about FAST and stuff, so. It's something we can definitely still explore and to see how we can collaborate.
So those towns have their own clinicians.
I know Fairhaven, they use clinicians out of New Bedford, just similar to like Westport using clinicians out of Fall River, they use them out of New Bedford. I think Dartmouth uses the same service out of New Bedford as well.
There is a group, which its name is escaping me, but it has to do with public health departments. It's an organization of all the public health departments, and they have somebody that's in that group that will help create that contract in the process of bringing the communities together and having some kind of an agreement. They are helping communities do that. So it wouldn't be something that we would have to create. They could create it for us. And I have not reached out to any other communities. I did ask in the collaborative that we are in about use of funds, and we've already lost one member of the collaborative. They've dropped out. And some other collaboratives just gave their money to the boards of health to distribute. So it's going to be a matter of contacting the boards of health and finding out what they're going to do. And I can try to do that.
If you'd like, I could do that. I can make some calls.
Okay.
We can talk about that later.
All right, that would be great.
I'm just pulling up the Dartmouth, they have a group, the Advocates for Addiction Recovery and Treatment, that's, I guess, somewhat analogous to our committee. That's the body, and there's a contact person on their website, Dolores Joseph.
Oh, yeah, Dolores. I know Dolores.
Yeah, and they meet monthly at Town Hall, so, yeah, worth a conversation with them.
Do they have the next meeting?
Let's see if I click that.
Because that would be something I would want to go to.
Yeah, that's a good idea.
You can call Dolores and find out when
Yeah, I
the
don't,
meeting is.
I don't see it here, but they have some websites on reducing the risk of overdose. There's some
Okay.
town websites that are interesting too.
All right,
Yeah, it doesn't say.
I'll investigate that because I would like to go to that next meeting.
Great.
All right, is there any other things that we need to plan for? We know RFPs are going to be coming up, and the reason why I put review of timeline, because I just wanted to go over the timeline that we set up. And I'm going to go into May. So we have, let's see, finalize and post RFPs. So we are not there yet. We were going to collect data by the end of May, and then we were going to start looking at creating the request for proposals. We are still collecting data, but I think that we need to readjust and look at when we can start asking the community. So what are the thoughts of the committee about, our goal was to, by the fall, have recommendations for the select board on where we want the money to be spent, or what proposals we are supporting.
Proposals is a strong word, I think. Are you going to have proposals by the end of the summer?
That was the original plan, but I
That was
think
the original plan.
now we're revisiting.
I'm asking you now on June,
Right, no, and that's what I'm saying, we're going to, because on the agenda, I put, review the timeline. So I think we need to review the timeline. We said this were the plans, this is what we were going to do. So where do we think we need to go from here?
Well, we have to write one up.
I think collecting more data from like STAR is extremely beneficial as to what resources are lacking for residents within our community, like what they need. Before we do a proposal, I think we need to know.
I just think because we can be in a mode of collecting data and hearing presentations, and then we start missing our own deadlines. And so, I mean, today was very helpful. I wouldn't take today back, but I think, and I think the program we had earlier, the FAST program, was an excellent program in terms of getting data and giving us ideas. And I think all of us have some ideas today in terms of the scale of what we think we can do and how we might be able to do it with them, or how we could do something like that independently, with some support from providers. That was my only point, was that we're getting some ideas, and we probably should revisit the deadlines and deliverables and see how far we are from those deadlines and deliverables. We can't do that all at once, but that may be a topic for the next meeting.
Okay. As a select board member, what would you like to see before we present anything to the select board?
I mean, I would be ready to I would have the RFP ready to be released before I went with the presentation. Because that's concrete. And everybody in the select board, for the most part, isn't going to be as tuned in as members of this committee are. So, I mean, I think we just come in with almost okay, we said we were going to do this. We've been doing this, this, and this. And now, we'd like you to review the RFP, provide, and I would make this, if there's a presentation, wouldn't make it 10 minutes, if that. And say, make it succinct, crisp, and this is what we're recommending. Any questions?
So since we had that we were going to, over the summer, or towards, I guess, late summer, ask for RFPs, and we were planning on presenting sometime in the early fall, are we still on track to do that or not?
I would think not, we're not ready to present funding recommendations at that date. But what I hear Craig saying is present the RFP before we actually release it for grants for the select board to review. So that I could see September, because I think we once talked about having it for August, and you said that's not a good time. But so if we basically take the next 2.5 months to put together an RFP, we can start it, and then kind of what we want is some criteria or priorities we'll get even more solid, by next month with more data. But then we present it September. Once it's approved, we can release it. So it's moving it back about 3 months, a quarter, and then get, late October, or, give people a couple months, like late October or sometime in October deadline, roughly. So I guess the goal would then be by the end of the calendar year to make a recommendation for funding, roughly?
Well, we don't need more than 4 weeks for people, 4 weeks from approval.
Right.
I mean, you're not asking the select board are going to approve the final recommendations for funding. But that in-between step is to make sure the committee is aligned with the majority of the board.
Right.
And so therefore, we don't go to solicit RFPs and review RFPs, and we don't have a good sense of the temperature of the select board in terms of what they're looking for. We, in terms of types of proposals. And the big thing will be scale.
Yeah.
We're not at a big scale. So we're going to have to talk about how do you, we're listening to programs, and every time I listen to program presentations, I say, okay, but we're not going to be at that scale. So how do we take the best ideas that we're hearing and rescale it to the resources that we have available?
Okay, thank you. Because I really need your input into the process. You're a process guy. I remember you saying that at one of our meetings. so that when we are beginning to solicit from community members, either requests for proposals or even when I keep thinking about the police department and how do we support when the funds aren't there anymore? How do we support the police department? What does the police department need to continue to do what they've been doing and maybe even do better? And, what kind of funds are they going to need? That's why I keep saying to you, think about what it's going to cost so
I
that you can
appreciate that.
present that
I
too.
just want to let you know, I will do everything I can to make sure that this still goes on with our officers going out there. Like, that is a priority. To me, it's a priority to our department. If I have to get creative in saving money, other ways to allocate money for those officers to do that, I will do what I can. So I just want to put you at ease saying, like, funding,
Well-
don't worry about the police. Like, we'll do what we have to do to make it work.
But this committee,
Sure.
right, we know we have funds coming till 2028. And so if there's a way for us to support that continued programming.
Sure.
If funding is an issue, then I would like to do
I
that.
appreciate, it might be Narcan, we talked
Well-
today. It might be not only for the officers to go out, the two dedicated officers to go out with the clinician, but it might be our officers are running short on Narcan on the street. It might be some sort of that type of request that we might have.
And that strikes me as we think about moving the timeline back and at the same time the urgency and our lateness in even getting money out. I might say we could consider, and we'll have to come back and think about this, could we, separate from the RFP process, recommend a purchase of Narcan for the town and some strategies to distribute it via first responders, via the Board of Health, via partnerships with, these other community organizations, via providers in town, et cetera. So I would just put that out there as one thing that,
But do we have a Narcan shortage now, or are we anticipating one?
well, I think there's two things. One, there's a need to distribute Narcan whether there's a shortage or not, just because it is life-saving and it has been a key factor in reducing overdose. So that's a good thing regardless of shortage or not. And then we don't know the answer to
I'm
that.
trying to stay on the funding line. Okay?
Yeah.
So as a funding question, it's a question, is there a supply issue now? Or is it something that, if you're talking about a set-aside or something like that, an in-case fund sort of face? Because that is a frontline response that we are currently offering, and it's important, and it's, you're hearing that we're already cutting, what we have is concerning because it does have an impact.
Right.
But and it may be or may not be related to the RFP, but and so that, to your original point, well, we're not going to kick the can down the road so far that if it becomes a crisis, we don't have the ability to
Right.
respond.
Right. Yeah.
And maybe we do something like an emergency response or a critical situation response, whatever the language is. Because it's not preventative, it's an intervention, both literally in terms of the activity and as well as our activity as a committee to make protecting that supply availability
Right.
a priority.
Yeah.
I think it's just putting it on our list and communicating and making sure, putting our ears to the pavement, so to speak, and hearing if there is going to be a shortage, where are we at, what do we have for an inventory? I'm talking police and fire-wise. And then going from there, and either myself or the fire representative, then coming to the board and saying, or the committee, hey, this is what's going on. We're projecting a shortage. We're going to need X amount. I mean, right now, we're doing fine, but I think it's something just to keep on the horizon with, at least for police-wise and fire-wise.
And I guess the other question is, do we have capacity to, because you suggested tabling, if we had an additional stock,
Sure.
that could extend beyond what you're doing in the follow-up visit. So that's what I guess I'm suggesting, not only to replenish your supply for your current activities,
Right.
but to have a more proactive supply of this life-saving medication that can be used, by the Board of Health, it could be by a community group, it could be a school group, it could be, wants to have it available at their event or at an educational event, or, so that would be something to consider, sort of along the lines of what you're saying, a critical resource. We don't want to wait longer to increase access for Westport residents to this critical resource. Okay.
All right, great. Thank you for the direction on next steps and the planning, all of you. So I would like to just go back now from that to topics not reasonably anticipated 48 hours in advance, which for me is opening up to the people in the community that are here, because I know there are some stakeholders here. So if anybody in the audience would like to come up and say anything or introduce yourself and say why you're here, you are welcome to do so. You can sit there.
Hi, my name is Jim McKenna, and I worked in the treatment business, behavioral health treatments, and I started in 1974. And I've worked in all aspects of this treatment, and I've run a lot of programs. And I retired in 2015, and then I get out of retirement, and I get involved in Rhode Island, and I opened up a men's sober house and a women's sober house and an outpatient clinic. And then I retired again, and I'm always retiring, and I'm always getting, I'm always interested in the problem. I did have a cousin that died from an overdose, so I'm obviously very aware and always looking at what's happening with the, what people are doing with the overdose money, and what can be done, and what we can do as a community, and what I can do. And I just wanted to find out, I live in Little Compton, which is right near the line, and I ran into Pam, and I got involved. She told me about the committee, and invited me to come and listen and see what was going on. And so, hopefully, while I'm here, and I can, any input that I can have or anything that I could do to help out, I would be more than happy to do that and be a resource. Thank you.
Thank you.
Thank you.
Okay, if there's no one else, oh,
As soon as I find my way out.
Feel free to move a chair.
Thank you. My name is Blair Tatman. I live on Main Road in Westport. I had a 20-year career at STAR with dual diagnosis patients as well as detox patients and outpatients. I think what I want to say is I don't think you're going to find any new news in the data. It may be interesting, but it's not going to tell you, in my mind, a whole lot about what is going to be useful, because the people we've seen in the last couple of weeks have their feet on the ground there. And particularly, I think Nikki and what she's proposing, or what she's describing, is right at the center of what a community can invest in to get multiple layers of access readily available. And that's the key, in my mind, is you don't have to think about, if you're a drug user, you know where the resources are. Pretty much, if you've gotten really involved, you and your friends know where the resources are. The easier it is to connect to them, the more likely you're going to use them. An overdose is its own situation. I'm glad that people are talking about quick responses and Narcan, and the safe space, I think, is brilliant. But my personal bias is I don't think the numbers will change anybody's point of view on what's actually needed. It's going to be a matter of what resources you have to work with in a political climate, et cetera, that's going to make things difficult to figure out how to use it. Thank you.
Thank you, Blair.
Thank you very much.
It's very helpful to hear perspectives from people who are in the community and who have done the work. So thank you both for speaking. All right, well, if there's no other business, I would entertain a motion to adjourn.
So move.
All in favor?
Aye.
Okay. Thank you, everybody.